Hello, everybody. Can you listen to me? Hello, everybody. Hello, everybody. I'm Dr. Abdul Hadi. I am recently joined EMED Masters at
आवाज तो ठीक है
MRCS.
ना अपना मोबाइल की आवाज
Hello? Hello? Okay. Hello, everybody. I'm Dr. Abdul Hadi. I hope you are all doing well. I recently joined EMED Masters as MRCS tutor. Uh, uh, the reason for joining the EMED Master is that it is as you all know, there is an online platform that helps medical professionals succeed in their goals of aspiring the MRCS and other courses because it provides them with high quality courses and study materials that help them gain their goal. So regarding MRCS, I have recently joined and I recently given the exam in 2023, and I have completed my AFCPS training in orthopedics. So it's quite related to me as because of my surgical professional. And if you are all going to give it sit in this exam, this will help you in your surgical career, especially if you want to work in countries like UK and Ireland. This will help you a lot in building your CV and in building your surgical skills. So today it's a small webinar on orthopedic anatomy, where we'll discuss about the key essentials for MRCS party. So first we will get to the introduction to the orthopedic anatomy. As you can see in anatomy, the bulk of the MRCS part A syllabus is anatomy, especially the part A I'm talking about. As you know, there are in part A there are two exams. Basically, part one, part A, MRCS part A, paper one and paper two. In paper one, there are about 90 MCQs directly from anatomy, and in paper B, there in MRCS paper 2, there are approximately 40 MCQs directly related to the surgical anatomy or orthopedic surgery, trauma and orthopedic surgery. So you can see that how much bulk it carries the anatomy portion, and most of the students who आवाज नहीं आ रही? Can you listen? Can you listen to me all? Can you hear me? Hello.
Yes, it's heard.
Okay. Can you all hear me? Okay. Okay. Should I continue now? Okay. So basically, the orthopedic anatomy is a key component of the MRCS part A, focusing on the structure and function of the musculoskeletal system, because the trauma portion and your surgical anatomy is based on orthopedic basic knowledge. You have to know these if you want to get through the difficult part of the MRCS. So here we'll discuss about the skeletal system, which includes the major bones, their functions, support, protection, and movement, and especially the joints and their mobility, and what structures support these joints, what are the types of these joints, and are the type of movements which occur at these joints. And if one or two movements are defective, we have to know the pathology behind that and the physiology behind that, and then we have to correct them, and that comes that roughly sums up the whole of the MRCS party. So basically the muscular systems which support these joints and bones, and then the tendons, ligaments, and cartilage, which are again building the structure like rolling joint stability, movements, cartilage, and reducing friction. So, orthopedic anatomy is crucial for MRCS Part A success due to the following reasons. As I told you earlier, that there is a high exam weightage, as there are 90 MCQs in paper one and about 40 MCQs directly from paper two, which are directly related to the anatomy. All the MCQs are, of course, indirectly related, but these about 130 MCQs are directly related to the anatomy portion. So this will form the foundation of surgical knowledge and application in surgery, improve problem solving. And if you have good anatomy, you will definitely will help in giving the paper two also. So what is the overview of the musculoskeletal system? So first is the component of the musculoskeletal system are the bones, muscles, joints, tendons, and ligaments. So the bone types, bone can be cancellous bone or the cortical. These are basically bone parts of the bone. Some the middle portion, or you can see the diaphysis is the cortical portion of the bone, and the ends of the bone. The metaphysis is basically the cancellous part of the bone. So muscle types, of course, muscle related to skeletal system are skeletal muscles, and the other muscles are in the gut are the smooth muscles, in muscles in the heart are the cardiac muscles, and and we will later on discuss what is the difference between these three types of muscles, and what are the receptors in occurring on the present on these types of muscles, and what type of drugs occur on these types of muscles. And later on we can get through these different types of drugs and the actions on different types of muscles. So the joints, the joint can be a synovial joint, it can be a fibrous joint, or it can be a cartilaginous joint. uh, Common disorders of the musculoskeletal system, it can be a fractures, it can be arthritis, osteoporosis, muscle sprains, strains, and the key concepts here are the bone healing, joint function, muscle function. So these are quite a general overview of the musculoskeletal system, what we'll be going through during the lecture. So, bone anatomy basics is basically bone is a biological structure. It's not like a wooden structure or like something which is just hard and nothing going on in it. It is everything is going within the bone, outside the bone, and bones are classified basically into long. Hello, hello. Bones are classified into long, short, flat, and irregular types, each serving unique function. So, understanding the microstructure of the bone, including the cortical and trabecular bone, is important for recognizing various pathologies and their implications in surgery. Okay, so what are the joints of the body? What are the functions of major joints of the body? What are the function of major muscle groups and tendon ligament? We have already gone through these things. That uh, a general overview is that all bones provide basic strength and support the system. Joints provide mobility, and the major joints provide free mobility. Like the knee joint, it provides flexion, extension, and some rotation. And the hip joint, it's a ball and socket joint, so it provides uh, three-dimensional movement, both flexion, extension, abduction, adduction, medial rotation, lateral rotation. Like the ankle joint, the subtalar joints, and some joints have limited mobility, like the joint in the skull, the syndesmotic joints. They have no to limited mobility. They help at the children. They are cartilaginous, so they will have some expansion there. But in adults, they fuse and there will be no mobile movement there. So in muscle groups, regarding muscle groups and functions, so again, like the skeletal, smooth, and cardiac muscle types, each having its own receptors, its own functions, and the drugs which act on these muscles are different. So we have to know these things before or during the preparation, so that we can have full confidence in appearing in the exam. So in tendon and ligaments, we have to know have you have to know the good knowledge of the tendons and the ligaments which are attached to the joints and the bones, especially the ligaments which support a joint. We have to know these ligaments, especially their names, everything. We have to know them. We cannot have a good sound knowledge of anatomy without knowing that ligaments which support a joint. Without knowing these, we cannot go through these. We cannot get through the exam easily. So let's talk about the fracture management because fractures are very common and they are commonly asked questions in MRCS when they are asked about different types of fractures, like old age fractures, like young fractures, and then management, open fractures, closed fractures. Everything has a different protocol of management. So we have to know these protocols before we embark on attempting these questions. So whenever a fracture comes, what we have to do? In open fractures, the treatment is different. In closed fractures, the treatment becomes different. Open fractures, always the treatment constitutes an emergency. You have to debride the wound and you have to stabilize the fracture with the help of an external fixator. If there is a large wound, if there is vascular compromise, you have to revascularize the structure. If there is only the open wound, we have to call the plastics and you have to involve the plastics and coverage of the wound is necessary. And you have to plan it within 6 to 12 hours. So the principle here is always in open fractures, debridement fracture should be fixed. First, you have to debride the wound, then you have to fix it with the help of an external fixator, and you have to do it within 6 hours. And before transferring the patient to the theater, you have to give antibiotics. You have to tetanus prophylaxis according to uh, uh, the tetanus protocol. You have to ask the vaccination protocol, the immunization state of the patient, and then give the tetanus prophylaxis. And IV antibiotics should be given in all open injuries. So a simple question here. So a 42-year-old skier falls and impacts his hand on his ski pole. So on examination, is tender in the anatomical snuff box and on bimanual palpation. X-rays with scaphoid views show no evidence of fracture. What is the most appropriate course of action? Can someone tell me the answer of this question? Hello? 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 Okay, so as you can see in this question, the X-rays show no evidence of scaphoid fracture, but there is pain on his palpation of the endometrial snuff box, which means that there might be a subacute fracture, which is not evident on the current X-rays. So the protocol here is to wait for 14 days and again review the patient after 14 days. So review after 14 days. So what should we do in these 14 days? Initial fracture, we have to splint the wound. We have to splint the wrist joint. So how can we splint? There are two options here: application of a tubic grip bandage and fracture clinic review, and application of futura splint and fracture clinic review. So the best thing is you just splint with the help of futura splint and fracture clinic review after 14 days. These two options and the tubic grip bandage, basically simple bandage like a clay bandage, but tubic grip is having a good grip over the bandage, but it does not provide any splintage to the fracture. So the best treatment would be to apply a futura splint and fracture clinic review after 14 days, and then we will again see the radiographs. And at that, after 14 days, if patient is still having the pain in his endometrial snuff box and X-rays still show normal anatomy, then we can go for MRI to confirm our diagnosis and to rule out if there is fracture present or not. Okay, so bone fractures. The basic biology behind the bone fracture is that bleeding vessels in the bone and the periosteum are there. So whenever the fracture is there, it extensively bleeds. First, there is a hematoma formation, the clot. This is basically how the healing process continues. So, clot hematoma formation, initially the clot organizes over a week. Then the periosteum contains osteoblasts which produce new bone formation. So when there is first stage is the hematoma formation, then there is a soft callus formation. So osteofibroblasts come into the hematoma, they organize into osteoblasts which lay the new bone. Mesenchymal cells are there which produce cartilage. So chondroblasts and osteoblasts are there. So this whole tissue of the connective tissue and the hyaline cartilage is forms the callus, which is a soft callus. Now, as the new bone approaches the new cartilage and chondral ossification occurs to bridge the gap. So basically, then the trabecular bone forms and then there's a reorganization of the callus and the soft callus is converted into the hard callus. That's why the trabecular bone is reabsorbed by the osteoclast and replaced with the compact bone. So this is known as uh, secondary bone healing. Yeah, or means that the first there is a step is the hematoma formation, then hematoma resolves the soft callus formation, then there is a bony callus formation, and the final step is the remodeling phase. So it has different durations. The hematoma stage lasts for 7 days, then 7 to 21 days is basically the soft callus formation day, and the 3 weeks to 3 months it's the hard bony callus formation, and from 3 months to 2 years there is a remodeling stage. So different factors that affect bone healing, which includes malnutrition, bone disorders, systemic disorders, drugs, type of bone involved, degree of trauma, vascular injury, which is very important. Vascular injury, you have to revascularize whenever there is fracture present. If the limb is salvageable, you have to see if the limb is salvageable. If the limb is salvageable, you have to revascularize. Degree of immobilization, intra-articular fractures, separation of bone ends, the age and the infection. So early age in young children, there are more chances of healing than in older patients. So what is osteoporosis? Osteoporosis means simple weakening of bones, porosity of the bones. The literal meaning is the porosity of the bones. Basically, bone atrophy with reduced bone tissue volume, generalized or localized. Characteristics include reduced osteoid matrix, which is normally mineralized. This is distinct from osteomalacia, basically because abundant but poorly calcified osteons, thin bone trabeculi, decreased tensile strength. Basically, what is osteoporosis? Basically, everything starts to decrease with age. Everything starts to decrease. The mineralization of the bone start to decrease. Everything is there. All materials are there, but they all tend to decrease unanimously. You will see that the person was normal, but now he having increased risk of fractures. There will be a sudden fracture with a low intensity trauma. And how will you identify the patient? Simply, you can see the X-rays, and you will see that the bone quality is decreasing. The calcium content is half. If you see the basic gold standard investigation for osteoporosis is the DEXA scan. So you can order a DEXA scan to see whether the osteoporosis is happening or not. So medications include bisphosphonates like alendronate, ibandronate, sindronate, zoledronic acid. Non-bisphonates like loxifene, denosumab, different types of hormones, replacement therapies. The supplements include calcium and vitamin D. So prophylaxis should be considered for all individuals at risk of fragility fractures. A simple question is an 80-year-old woman has a hip fracture. So hip fracture occurred in an 80-year-old woman. Her calcium is normal. She has never been diagnosed with a case of osteoporosis. Apart from treating the hip fracture, what additional intervention should be considered? So what you all think might be the cause of her fracture of the hip at 80 years old? Hello, hello, hello. So basically, hello, can you all listen to me? Hello, hello, hello. Okay, so basically, the hip fractures are mostly at this old age are mostly from the uh, risk of osteoporosis, and definitely osteoporosis has occurred because it starts even after 40 years, and some also because the peak bone age at 32 years, and now the cycle has started to reverse, and now the patient is having decreased bone mineral density. So we have to supplement the patient with the help of vitamin D, calcium supplements, and bisphosphonates to prevent her from further fractures. So option B. So what is osteomalacia? Normal bone tissue but decreased mineral content as in rickets if we are growing in growing children, osteomalacia in adults. So basically osteomalacia and rickets is a disease of the young age, and osteomalacia is a disease of the adults. It has different types like vitamin D deficiency rickets, renal failure, drug-induced vitamin D resistant rickets, and liver diseases. It all causes like osteomalacia and rickets in children. Investigation will reveal there will low calcium, phosphate, vitamin D, and raised alkaline phosphatase level. Again, treatment would be calcium and vitamin D supplements. The features would be in osteomalacia, of course, adults will present with bone pain and fractures with muscle tenderness. And in young children, you hear that the typical rickety rosary bored legs, hypocalcemia signs. So, a 65-year-old Asian female presents with extracapsular neck of femur fracture. Investigation show that her calcium is decreased, phosphate is decreased, and alkaline phosphatase is raised. And the patient is 65-year-old. So, if it was a young patient, it would be rickets. As in an older patient and having decreased calcium phosphate and increased alkaline phosphatase, that's the key point, alkaline phosphatase. So it indicates that it is a case of osteomalacia. So again, nervous system overview like coordinates, movements, and sensations. So the key components are the spinal cord and the peripheral nerves, which are involved in taking the signal from the brain to the peripheral nerve, take the signal to the last dermatome or the myotome, where it supplies and the movements occur. So common orthopedic condition, you have to familiarize with the common orthopedic conditions, the common orthopedic fractures, common dislocation of the joints and their implications, and the joints relate and the joints having more chances of instability, and the bones having more chances of non-union. You have to know these bones, which have to know the fracture geometries and different fractures, which are more prone to more non-union, which are more prone to fractures and different fracture, different ages. You have to know the physical slips. Uh, these familiarity with these common orthopedic conditions will help you in understanding the basic concepts and the fundamentals of MRCS part. So image techniques in orthopedics like X-ray, MRI, and CT scans are essential for diagnosing orthopedic conditions. As we discussed in the case of scaphoid fracture, the initial slide, where we discussed that patient had a fracture, had a pain in his anatomical snuff box, but there was uh, but there was no fracture seen in the view, the scaphoid view. So basically, it indicates that the fracture might not be there, but the subtle fracture might be there. So we can, if X-rays are not showing anything, we can get, of course, the MRI and the steps we can take before doing the MRI. So we can initially apply the future splint. After 14 days, we can again apply the again review by taking the radiographs, and radiographs are clear in the MRI. So different surgical approaches to different fractures, different cases. We have to know these approaches, and during these approaches, what type of complication might arise. We have to know these things. So last question here is the 78-year-old man complains of long history of shoulder pain and more recently weakness. On examination, active attempts at abduction are impaired. Passive movements are normal. What is the most likely diagnosis? Okay, so can anyone shed light on the this question? Because it is asking that there are active attempts at abduction are impaired. A patient having shoulder pain, long history, the chronic history of shoulder pain, and now active abduction is impaired, but passive movements are normal, meaning that the patient is not able to use his own muscles for shoulder movement. But if someone else moves his joint, it is freely movable, meaning that there is no adhesions in the joint. But the active movements are lost, meaning something happening with the patient's own muscles. So what muscles are attached to the shoulder joint? Of course, the rotator cuff, and the rotator cuff tear might be the reason patient is having these symptoms. Okay, so study tips are the effective study strategy include active recall, spaced repetition, and group study. Focus on understanding rather than memorizing. Utilizing resources like anatomy apps and quizzes can enhance your learning experience. Okay, conclusion and key takeaways. Mastering orthopedic anatomy is essential for MRCS Part A success. Focus on the interconnection between structures and their functions. Regular revision and practical application of knowledge will greatly enhance your proficiency in the field. So, if they are want to ask me any questions, you can ask here. Hello, if you want to ask any questions, I'm here. Which course you recommend? Okay, so basically, uh, all courses are good, but here EMED Masters we have blended a course here for easy study. You need at least 4 to 6 months, depending upon your previous knowledge. If background knowledge is very necessary. If you are if you are surgeon in training, that would become very easy for you to get through the MRCS part A and part B both. No, no, 3 months are not enough. Uh, 3 months, I don't think 3 months are enough. At least 4 to 6 months. Plan your study schedule for at least 4 to 6 months. Less than that, you are at risk. If you have a strong background knowledge, then of course you can study in 2 months also. But it all depends that how much background knowledge you have. If you are good in anatomy back at the time of during your MBBS tenure, when you were studying anatomy and physio and patho, if you are were good at that time, then you can pass with flying colors, no doubt about that. Any other question? Welcome, no problem. Okay, but okay, so I would like you all to start your mind and start preparing. If you want to give exam in January, the seats are open now till October, and the exam will take place in January. So you have about October, November, December, January. So 4 months at least you have there. If you are free and you can give at least 6 to 8 hours daily study time, then it is sufficient time for you. Okay. One more thing I would like to share it with you that before or before you start preparing or before you embark on this journey, always remember that this is the exam or related to your surgical experience and surgical knowledge. If you want to pursue a career in surgery, then this is the best exam you have. Plus, some persons say that the shortest or the easiest path compared to the plab route for getting the GMC. So I would say that again, if you want to pursue a career in surgery, the best this is a great route. You can skip the plab route. But if you want to have a medical career, then this might be difficult for one reason that its major bulk is from anatomy, and the second reason that it's a membership exam. It's not a registration exam, so it will be a diploma displayed always on your wall on your clinic, and you will have this document always with you wherever you go, wherever you give the interview. This is your degree. So if you are pursuing a surgical career, this will help you a lot.